Alright, so this is an introduction to Chapter 17, Cardiological Emergencies. The role of the paramedic was created more than 40 years ago to treat patients with acute myocardial infarction, AMI. AMI occurs whenever there's sudden narrowing or complete occlusion of the coronary artery. It causes myocardial tissue necrosis. It's death of heart tissue. The American Heart Association says that one person with an AMI in the United States happens every 40 seconds. The anatomy and physiology review, structure and function. So we have cardiovascular system. It's composed of heart and blood vessels. Primary function is to deliver oxygenated blood to nutrients to cells in the body, responsible for delivering hormones, transports metabolism, waste, and products from cells to recycling and waste disposal sites. That is your kidneys. The heart has four major chambers. We have the right atrium, we have the right ventricle, left atria, left ventricle. You can see the arrows showing where blood flows and at which point in the heart, all the way to the end. Blue stands for deoxygenated blood, while red is oxygenated blood. The oxygenation happens during external respiration in the lungs. This is when gas is exchanged for CO2 for O2. So let's see. We got the vena cava. This is inferior because it's below. Superior is above. And then you have your pulmonary arteries that go in and out through where the lungs are at. So you're going to go through the right atrium through here and then into the right ventricle. This is your tricuspid valve moving into your pulmonary veins. From your pulmonary veins, blood comes back through pulmonary arteries, then through the pulmonary veins back into the left atria. Through the left atria, it's going to hit this valve, that's your bicuspid valve. And then back through the left ventricle all the way through the aortic arch back into the body system. In the right atrium, it receives blood flow with oxygen from the superior vena cava, the inferior vena cava, and the coronary sinus. The left atrium receives freshly oxygenated blood from the lungs by way of the right and left pulmonary veins. The atria then contract, pumping blood through the AV valve into the ventricles. Then there's the right ventricles. The right ventricles pump deoxygenated blood into the lungs. The left ventricles pump oxygenated blood through the rest of the body. When the left ventricle contracts, it produces an impulse that's palpable at the apex of the heart, the apical, can I say this word? Yeah, apical impulse, also called the point of maximum impulse, PMI. A septum separates the right and left sides of the heart. The interstitial septum separates the left and right atria. The interventricular septum separates the right and left ventricles. The septum separates the heart into two functional pumps. The right atrium and the left ventricle are composed of one pump. Sometimes this is called the right heart. A low pressure system of pulmonary circulation, and then the left atrium of the left ventricle compose the other, sometimes called the left heart. A high pressure pump, systematic circulation. The myocardium is the middle layer of the heart wall. It comprises of mostly thick cardiac muscle tissue, responsible for cardiac contractions and efficient ejection of blood. There are two major coronary arteries that supply blood tissue to the heart. The left main coronary artery, LMCA, and this is the largest in diameter and the shortest of the myocardial blood vessels. It divides the left anterior descending artery, LAD, and the circumflex artery. The areas supplied by the coronary arteries differ among patients. The LAD supplies blood to the anterior surface of the left ventricle, part of the lateral surface of the left ventricle and the portion of the interventricular septum in most patients. Circumflex artery supplies the left atrium part, and the lateral surface of the left ventricle, the inferior surface of the left ventricle, is in about 15% of people the posterior surface of the left ventricle. I don't know what I'm saying right now. The right coronary artery, RCA. Branches supply the blood to the wall and the right atrium and ventricle. The portion of the inferior part of the left ventricle and portions of the conduction system, the SA node, the sinal atrium node, in about 60% of people, and atrioventricular bundle of about 85%. So basically, everybody's built a little bit different, and your heart floods itself with blood and feeds itself in different ways depending on who you are. That's that in a nutshell. So this shows a coronary artery, anterior and posterior view. So here is your posterior view. This is as if we were looking through the back of somebody at the heart. So you can see in the rear, we have our giant coronary sinus, and we also have, let's see, this is our left ventricle. This is our right atrium here. Pulmonary veins and pulmonary artery, these are what's feeding the lungs. Your aorta, this is what's feeding the rest of the body. Everything that's you. Inferior vena cava, superior, this is what is feeding the heart from the rest of your body. Posterior descending coronary artery and posterior intraventricular groove. And you have your right ventricle here, right atrium there. So this is if we were looking at the heart straight on at somebody through their chest. So superior vena cava is behind it. Aorta, but still there, nothing too special. Your pulmonary arteries are kind of out of view at this point, and you have your right coronary artery and the coronary sulcus. So this is connected right here to the aorta. The inferior vena cava, again, and then you have your coronary vein. It's less viewable from here, from the front. So you can see more of your coronary artery from the front and more of your coronary vein from the back. Reverse that. Reverse what I just said. So you have more view of your coronary artery from the front, and your veins are viewable from the back. Cardiac cells have 4 important properties that help the heart function efficiently. It has automaticity, excitability, conductivity, and contractility. So these are what a lot of medications that you'll be taking for the heart are going to perform. Some sort of like a beta blocker, alpha blocker, calcium channel blocker. Any of these types of medicines that are going to affect the heart are going to affect some of these different traits and functions in the heart. Some of them will affect more than one. So it'll affect 2, like epinephrine is, what is that, beta 1? I can't even remember, but epi does 2 different things. The cardiac conduction system comprises of 6 parts. You have your sinus atria node, your SA node, your atrioventricular node, the bundle of His, the right bundle branches, the left bundle branches, and the Purkinje fibers. So this is like the nervous system or cardiac conduction system within the heart. This is where electricity runs through. The sympathetic or parasympathetic nerves are stimulated, of course, and stimulation of each of those either strengthens the force of contraction or it increases the heart rate. This is the sympathetic. So sympathetic nerves. Sympathetic is fight or flight, so it's going to increase your heart rate. You got to run from the tigers, and also strengthens the force of contraction. So it's pumping more blood faster at the same time. This is what epi does. Stimulation of the parasympathetic nerve slows the rate of discharge of the SA node. This is going to slow you down. Slows conduction through the atrioventricular node, weakens the strength of the atrial contraction, can cause small reduction in the force of ventricular contraction. Patient assessments. Why is this so big? Let's bring that back. Dial that back for me. There we go. A patient with cardiovascular related symptoms may be young, middle-aged, or older adult. A systematic approach to the patient assessment is important. It seems like redundant information. The order of the steps for the following primary surveys differs depending on the type of cardiac patient. The order of steps in the primary survey is normally if the patient is found unresponsive and suspected of being in cardiac arrest, we are going to go to circulation first instead of airway because we want to check and see if they have a pulse. That's going to give us a lot more important information as far as bringing them back to life. History taking. We want to know if they have a history of any cardiac related symptoms. If they have acute coronary syndrome, ACS, they are a series of cardiac conditions that are caused by an abrupt reduction in blood through the coronary system. There are three major acute coronary syndromes. We have unstable angina, non-ST segment elevation myocardial infarction, that's your NSTEMI, and then we have ST segment elevation myocardial infarctions, STEMI. That's what we'd be able to pick up whenever we perform a 12-lead EKG. Common chief complaints in the patient experiencing an acute coronary syndrome include chest discomfort, dyspnea, fainting, palpitations, and fatigue. Chest pain or discomfort is often the presenting symptom for a patient with ACS. The description of discomfort for assessing significance, we're going to go through our OPQRST. So that is our onset, what caused this, our what provoked this? Did you just eat spaghetti? Quality, what is the quality of pain, 1 to 10? How bad is it? Does it radiate anywhere? How severe is this pain? And how long have you felt this pain for? When's the last time you felt normal? If the patient has more than one chief complaint, ask the patient which symptoms started first, which bothers him or her the most. Dyspnea and other chief complaints in ACS may vary in intensity. Difficult to assess because it is a sign and not a symptom. Dyspnea develops suddenly suggests that, one, there could be a pulmonary embolism. Embolism is a blockage, so there could be pulmonary embolism within the pulmonary arteries or the veins leading to the lungs. Now the person's struggling to breathe, and sometimes we'll be able to tell this if the person's coughing up pink, wispy spit, sputum, whatever you want to call it, because there's blood coming out of the lungs where they breathe in the spit. Acute pulmonary edema, this would be backed up blood causing swelling because the cells are not able to release fluids like they normally can, so you'd see pulmonary edema in the lungs, again making it difficult to breathe. They could have pneumonia. They could just have fluid in the lungs, any type of mucus. Airway obstruction, maybe they're choking on a Hot Wheels car. Dyspnea that occurs when exertion suggests COPD or left ventricular failure. So this is with the left side of the heart, the left ventricle. Paroxysmal nocturnal dyspnea is a sudden onset difficulty in breathing in which the patient suddenly awakens from sleep. Associated with LVF, left ventricular failure, usually begins 2 to 4 hours from the onset of sleep, often accompanied by coughing, wheezing, sweating, and a feeling of suffocation upon awakening. Usually improves after standing or sitting for 15 to 30 minutes. If your patient has a cough, then find out whether it is dry or productive. If your patient has fainted, try to determine whether or not the fainting occurred from a cardiac or non-cardiac episode. Cardiac causes syncope, including dysrhythmias, increased vagal tones, and heart lesions. Consider the cardiac cause if fainting occurs in a recumbent position, is provoked by exercise, if associated with pain, or if family history of fainting or sudden death is present. Patient with cardiac problems and their chief complaint of palpitations, it can be caused by either anxiety, lack of sleep, certain medications, caffeine, stress, cocaine, amphetamine use, heavy cigarette smoking, metabolic conditions, hyperthyroidism, changes in the heart's rhythm or rate, including fast rhythms, tachycardias, and early beats. So we want to ask about the onset, the frequency, and the duration of the symptoms in the previous episodes of palpitations. If there's a present associated with the symptoms, such as chest discomfort, dizziness, syncope, dyspnea, fatigue is common complaint in patients with impaired cardiovascular functions. Ask whether the fatigue began, how long it's been present, and ask about associated symptoms such as chest discomfort, nausea, dyspnea, and syncope palpitations. Patient may report feeling of other related symptoms, including feeling impending doom, nausea, vomiting, trauma involvement, hypoxia, and also inquire about the pertinent aspects about the patient's other medical history. Ask specifically if the patient has ever been diagnosed with coronary artery disease, atherosclerotic heart disease, angina, previous MI, hypertensive, and heart failure. Atherosclerotic is whenever the veins become more brittle and easier prone to bleeding. They could have a valvular disease or an aneurysm. Diabetes, renal disease, vascular, inflammatory cardiac disease, and previous cardiac surgery or congenital anomalies. They could be born with something. Secondary assessment, what is the skin color of the patient as far as if they could be, what am I thinking of? Diaphoretic, they could be cyanotic, cyanosis. Physical exam with cardiac complaint should emphasize that condition. Patient with low CO, carbon monoxide, and inadequate tissue. Is that low CO? Inadequate tissue perfusion may present with pale mottled or cyanotic skin. We want low CO. Low CO2, maybe? With low CO2, could be pale mottled cyanotic skin. Flush warm skin may be a sign of infection such as pericarditis. That is inflammation of the heart. Physical exam includes the following steps. Inspect the neck. Make sure is this seeing the whole screen. Well, now it is. Physical exam includes the following steps. Inspect the neck, tracheal position, inspect the adjacent structures and such as neck veins to estimate jugular venous pressures. Place the patient in the semi-Fowler position with the head slightly rotated away from the vein. Observe the height of the distended fluid column in the vein. Note how far up the distension extends above the sternal angle. Inspect and palpate the chest. We're going to take a break.